ventilation, and advanced oxygen therapies to navigating complex critical illnesses. This is a field where precision and expertise define outcomes. To excel, you need more than knowledge. You need mastery in applying it under pressure when every second counts. Elevate your expertise. Apply for the fellowship in respiratory critical care. This program empowers you to master mechanical ventilation, advanced respiratory support, and critical care strategies for patients with the most complex conditions. This is not just another training, it's a transformative experience designed for ambitious professionals determined to redefine their practice and impact. Learn from world-renowned experts. Gain clinical insights, practical pearls, and the latest evidence, all accessible from wherever you are. Our curriculum is comprehensive, covering the full spectrum of respiratory and critical care, from invasive and non-invasive ventilation, ARDS, and sepsis management, to ECMO and advanced rescue therapies. You'll gain practical, actionable expertise. Engage in live, interactive sessions. Present your toughest ICU cases. Collaborate with peers across the globe who share your passion for saving lives. This is your chance to strengthen your expertise, expand your career horizons, and join a community dedicated to excellence in respiratory critical care. The future of respiratory critical care is here. Are you ready to lead it? Applications are now open. Visit our website to begin your journey today. You are at the front line of life-saving medicine. From managing mechanical ventilation and advanced oxygen therapies to navigating complex critical illnesses, this is a field where precision and expertise define outcomes. To excel, you need more than knowledge. You need mastery in applying it under pressure when every second counts. Elevate your expertise. Apply for the fellowship in respiratory critical care. This program empowers you to master mechanical ventilation, advanced respiratory support, and critical care strategies for patients with the most complex conditions. This is not just another training, it's a transformative experience designed for ambitious professionals determined to redefine their practice and impact. Learn from world-renowned experts. Gain clinical insights, practical pearls, and the latest evidence, all accessible from wherever you are. Our curriculum is comprehensive, covering the full spectrum of respiratory and critical care, from invasive and non-invasive ventilation, ARDS, and sepsis management, to ECMO and advanced rescue therapies. You'll gain practical, actionable expertise. Engage in live, interactive sessions. Present your toughest ICU cases. Collaborate with peers across the globe who share your passion for saving lives. This is your chance to strengthen your expertise, expand your career horizons, and join a community dedicated to excellence in respiratory critical care. The future of respiratory critical care is here. Are you ready to lead it? Applications are now open. Visit our website to begin your journey today.
Hello, everyone, and welcome to our Respiratory Critical Care Fellowship webinar. Today is very special to us because we have, one of the most devastating diseases and condition that needs a multidisciplinary team approach to treat, which is pulmonary renal syndrome. I'm going to give you some introduction about our Respiratory Critical Care Fellowship, which is a 1-year online fellowship structured as 3 modules, 16 weeks each. And it doesn't depend on lectures, but more on clinical case scenarios, journal club, case-based discussion, and MCQs. Again, it's not a monologue, but rather a dialogue, bi-directional education, and it depends on a very smart technology and the platform that all of our fellows going to have all of the educational contents and scientific merits in the platform, and all of their activities and assignments will be monitored in the platform, and they will have both quantitative and qualitative assessment, not only based on their score, but on their engagement and their overall performance. Our first module of our Respiratory Critical Care Fellowship is focusing on the physiology, pharmacology, blood gas interpretation, acute severe respiratory tract infection, asthma exacerbation, and pulse oximetry and capnography, and a lot to focus on respiratory imaging. Module 2 is focusing on oxygen therapy and ventilation. So from non-invasive ventilation to waveform interpretation and invasive mechanical ventilation. And module 3 is focusing on advanced respiratory critical care management from non-conventional mechanical ventilation to ECMO and extracorporeal CO2 removal, nutrition support and respiratory critical care, and use of electrical activity of the diaphragm, esophageal balloon, and advanced monitoring in the respiratory critical care field. Again, it's only online, 1-year fellowship program, and we are targeting to identify our fellows' weaknesses and to improve it and to work to strengthen their clinical practice and their education. Upon completion of the 1-year Respiratory Critical Care Fellowship, our fellows would be experts in the field, will be graduated to trainer and mentor level, and will receive an American Association of Continuing Medical Education graduation certificate. We have a lot of fellows in our WICCM, and we are gathering also very good experts with diversity from all over the world. If you are interested and ready to join our Respiratory Critical Care Fellowship program, please go ahead and take advantage on the early 15 with a 15% discount that would expire by next week. Again, don't waste the chance and try to apply as soon as possible if you are interested. Now we are going to start our webinar. Here is our agenda. So we'll start with a case-based discussion by Professor Heba Assal from Cairo University. Then Dr. Faisal Albalawi is going to give us a differential diagnosis of pulmonary renal syndrome. Then Dr. Mohammed Omair from Saudi Arabia is going to focus on management of pulmonary renal syndrome. And our great organizer and board member, Dr. Fadi Aljamaan, is going to lead the discussion and try to help to answer the questions. With that, I'm going to let our first presenter, Dr. Heba Al-Jibali, to give the case-based discussion, but I just want to notify you that all of these educational activities has no value except we improve our patient outcome, and we try to apply this knowledge in our clinical practice. With that, I'm going to let Professor Heba to give the first presentation with case-based discussion on pulmonary renal syndrome.
Hello, everyone. My name is Heba Assal, Professor of Chest Diseases, Cairo University. Today, I'm going to discuss 2 cases diagnosed with pulmonary renal syndrome. The first case is a 71-year-old woman observed in the emergency department due to athenia, vomiting, and persistent cough. The patient had no history of fever and denied dyspnea or hemoptysis. During the past 12 months, the patient presented anemia and aggravation of renal function with progressive deterioration. On examination, she was pale, her blood pressure was 160/76, heart rate 74 per minute, pulse oximeter was 97% on room air. On chest examination, fine crackles were detected. Her labs show severe anemia, hemoglobin was 6.9, severe renal impairment, creatinine 4, blood urea nitrogen 201, potassium 6.3, with proteins and erythrocytes in the urinary sediment. The patient did not present coagulopathy with normal platelets and normal coagulation profile. Myeloperoxidase MPO ANCA was positive. However, anti-GBM and proteinase 3 ANCA TET were negative. CT chest revealed patchy ground glass haziness in a geographic distribution, confirming crazy paving, likely due to diffuse alveolar hemorrhage. Bronchoscopy was performed on day 4. Bronchoalveolar lavage fluid shows increased blood-stained aspirates in sequential samples with hemosiderin-laden macrophages on cytology. A diagnosis of severe pulmonary renal syndrome due to ANCA-associated vasculitis was made. So here, what is the most preferred first line for induction of remission in this case? Is it high-dose glucocorticoids alone? Is it plasma exchange plus glucocorticoids plus rituximab? Plasma exchange plus glucocorticoids plus cyclophosphamide? Glucocorticoids plus rituximab? Glucocorticoids plus cyclophosphamide? ANCA-associated vasculitis is generally treated with a combination of glucocorticoids and immunosuppressive therapy. Treatment is divided into induction phase, typically 6 to 12 months, maintenance phase of 18 to 24 months. Glucocorticoids are the cornerstone of treatment. Standard induction regimens include pulsed methylprednisolone for 3 to 5 days, followed by taper to 1 milligram per kg for the first month and further taper over the subsequent month. Glucocorticoids are typically continued at low dose for a minimum of 18 months alongside a steroid-sparing agent. Proteinase 3 ANCA positive typically complete an extended 24 to 36 month course given the higher rate of disease relapse. So here, combination of immunosuppressive therapy and glucocorticoids are recommended in organ-threatening disease. Rituximab rather than cyclophosphamide is the preferred agent. This was recommended by the American College of Rheumatology for induction of remission as it is considered less toxic than cyclophosphamide. The American College of Rheumatology recommend against the use of plasmapheresis in diffuse alveolar hemorrhage as well as patients with active glomerulonephritis. However, they suggest consideration in those who are critically ill or fail to respond to the recommended remission induction therapies, as well as patients at higher risk of progressing to end-stage disease. So answer 4 is correct. So the most preferred first line for induction of remission in this case is glucocorticoids plus rituximab. As we've said, rituximab here is preferred over the cyclophosphamide being less toxic. However, both are used, but if we are going to choose if the patient can receive rituximab, here the rituximab plus glucocorticoids is the preferred agent for induction of remission according to the American College of Rheumatology guidelines. What is the most preferred regimen and duration for maintenance of remission in this case? Is it intravenous immunoglobulin for 3 months, mycophenolate moftil for 6 months, azathioprine for 6 months, methotrexate for 6 months, cyclophosphamide for 3 months, rituximab for 18 months? Rituximab is associated with a lower relapse rate than azathioprine and methotrexate when used for remission maintenance after remission induction with cyclophosphamide or rituximab. So after induction of remission, it is better to continue on rituximab as it is reported to have lower relapse rate. Immunoglobulin supplementation at replacement doses should be considered if patient has hypogammaglobulinemia and is experiencing recurrent infections, which was not our case. Mycophenolate moftil was shown to have higher risk of relapse when given for maintenance of remission. Rituximab is preferred in maintenance of remission over cyclophosphamide being less toxic. The American College of Rheumatology recommends remission maintenance therapy for at least 18 months and potentially longer duration depending on patient-specific factors. So factors to be considered that make the patient at risk of high relapse is a previous relapse history, extent of organ involvement, if the patient has severe organ involvement, if the patient, according to the ANCA status, if the patient has protein A3 ANCA positive, these patients are more likely to relapse. So the most preferred regimen and duration for maintenance of remission is number 6 is rituximab for 18 months. And as we've said, if the patient has risk of relapse, this duration may be extended up to 24 to 36 months. However, 18 months is the standard regimen, and the patient usually receive rituximab for 18 months. As we have said, it is, if compared with cyclophosphamide, it's less toxic. And if compared with mycophenolate and azathioprine and methotrexate, studies has shown that it showed the patient that received rituximab in the maintenance of remission had much less relapse than those patients that received the other agents. Case number 2. A 26-year-old male ex-smoker admitted with hematuria and scant hemoptysis. He's hemodynamically stable and remains on 2 liters of oxygen via nasal plunge to maintain oxygen saturation more than 95%. He's diagnosed with a pulmonary renal syndrome due to anti-GBM disease. Which of the following would be the most appropriate initial management steps? Is it glucocorticoids and cyclophosphamide? Commence renal replacement therapy, plasmapheresis with glucocorticoids and cyclophosphamide, high-dose glucocorticoids alone. Anti-GBM disease or Goodpasture syndrome is a rare disease with a reported incidence of about 1 case per million. Men are affected more than women. The patient usually present in around 20 and 30 years of age. It's not a smoking-related disease, but smokers are more likely to develop diffuse alveolar hemorrhage in the context of a diagnosis of anti-GBM disease. Anti-GBM disease is caused by antibodies which are directed against type 4 collagen, a component of the glomerular basement membrane. The antibodies bind to the basement membrane, activating a cascade which results in the disruption of Bowman's capsule with resultant proteinuria and crescent formation. Most patients present with symptoms and or signs related to glomerulonephritis and diffuse alveolar hemorrhage. Clinical onset has been associated with smoking and respiratory tract infection. So the smoking and respiratory tract infection usually triggers alveolar hemorrhage in the patient with anti-GBM positive antibodies. The detected antibody level correlates with the severity of renal disease. Patients with concurrent diffuse alveolar hemorrhage tend to have more severe renal injury than those without diffuse alveolar hemorrhage. Anti-GBM disease is treated aggressively due to high mortality and morbidity. Plasmapheresis to remove the circulating antibodies is the gold standard treatment, usually performed for 2 weeks or until the anti-GBM antibodies are undetectable. In contrast to ANCA-associated vasculitis, the disease does not relapse, and immunosuppressive agents can be safely withdrawn within a few months. The largest experience in anti-GBM disease used high-dose prednisolone tapered over 6 months, oral cyclophosphamide for 2 to 3 months, and daily plasma exchange for 2 weeks or until anti-GBM antibodies were no longer detectable. So the correct answer for this patient diagnosed with the anti-GBM disease is the plasmapheresis with glucocorticoids and cyclophosphamide. Thank you.
Very nice presentation. And Dr. Fadi is going to introduce our second speaker, Dr. Faisal. Then all the questions should be answered by the end of this webinar.
Good evening, everybody, and appreciate it for Dr. Heba that she did a summary for our webinar before we started the webinar. So it was supposed to be actually a case presentation, just presenting for our webinar. But anyways, So appreciated for taking the perspective of the pulmonologist and intensivist for the pulmonary renal syndrome. And we invited actually our experts from the rheumatologist. We have both Dr. Faisal Albalawi, we have also Prof. Mohammed Omair, and I'm honored that we actually invited them from Saudi Arabia, that they are the experts from the rheumatology point of view. So now we appreciate and we actually thank Dr. Heba for her presentation and giving her prospect from the pulmonologist point of view. So now we will take the expert opinion from the rheumatology point of view. So we'll start with Dr. Faisal Albalawi. So he's a rheumatologist from King Fahd Medical City, a large center in the Saudi Arabia, and a rheumatologist, well-known rheumatologist in Saudi Arabia, who will start by giving us an idea about the pathophysiology of the diseases involved in the pulmonary renal syndrome, how to approach them, and then later we'll move to Prof. Mohammed Omair, who will go through with us about the management of the severe cases of pulmonary renal syndrome that usually present in catastrophic presentation in the ICU. So, Dr. Faisal, it's yours. So start, please, and thank you very much.
Hello, doctors. It's nice to be with you today in this meeting about pulmonary renal syndrome. My name is Dr. Faisal Albalawi, consultant internal medicine and rheumatology at King Fahd Medical City, Riyadh, Saudi Arabia. Today, I would like to talk about pulmonary renal syndrome, cutting edge and breakthroughs from the perspective of differential diagnosis, etiopathogenesis, and the clinical features. The points I will discuss them during the presentation. I will talk shortly about pulmonary renal syndrome from the scratch, and I will talk about differential diagnosis in this complex situation. Then pathogenesis of pulmonary renal syndrome will be discussed, and clinical features about pulmonary renal syndrome. The term of pulmonary renal syndrome is a clinical syndrome which includes a group of diseases associated with inflammation of smaller blood vessels located mainly in the lungs and kidneys. So, the inflammatory process in the pulmonary renal syndrome will cause very poor prognostic clinical manifestations in terms of alveolar capillaritis with hemorrhage and glomerulonephritis. The pathogenesis of pulmonary renal syndrome will be dependent mainly on the cause for this syndrome. Differential diagnosis in case with pulmonary renal syndrome, in which we should think about them once we are facing like these cases. So the first differential is ANCA-associated vasculitis in form of granulomatosis polyangiitis, GPA, microscopic polyangiitis, MPA, and eosinophilic granulomatosis polyangiitis, EGPA. GPA and MPA are presenting more commonly in terms of pulmonary renal syndrome rather than eosinophilic granulomatosis polyangiitis. The second differential is Goodpasture syndrome or anti-GBM disease. The third important differential is systemic lupus erythematosus, between two brackets, SLE, or non-ANCA associated vasculitis. Related vasculitis is like cryoglobulinemic vasculitis. And another differential is anti-phospholipid syndrome or thrombotic thrombocytopenic purpura. Important things to be excluded because they might present with similar picture of pulmonary renal syndrome is the infectious process, illicit drug use, especially among younger individuals in terms of cocaine and amphetamine drug abusers, and valvular heart disease in form of mitral valve stenosis. The etiopathogenesis of pulmonary renal syndrome, I will talk about the most common causes of pulmonary renal syndrome In ANCA-associated vasculitis, we have under this umbrella three important subsets. The first one is granulomatosis with polyangiitis, or GBA, in which the patient will have severe necrotizing granulomatous inflammation involving the respiratory tract and kidneys. It is characterized mainly by presence of positive anti-proteinase 3 antibody. Microscopic polyangiitis, it is another necrotizing inflammation but without granulomas, involving mainly the lungs and kidneys and associated more with anti-myeloperoxidase antibody. As we mentioned before, eosinophilic granulomatosis polyangiitis, it is characterized by peripheral eosinophilia and asthma. They are presenting less frequently than the previous two subsets in terms of pulmonary renal syndrome. The pathogenesis of ANCA-associated vasculitis, that in susceptible individuals, a specific trigger will stimulate the neutrophils, and the neutrophils will be more active and starting to express proteinase 3 and myeloperoxidase enzymes over the cell's walls. And these enzymatic antigens will be like more stimulating of the B cells to produce antibodies. So after that, the antibodies, once they recognize the enzymatic antigen, the neutrophils will be burst and destroyed. And as a result of that, nuclear contents will be released and reactive oxygen species will be present to form what is called neutrophilic extracellular traps. These small particles, what called in neutrophilic extracellular traps or nets, will circulate in the blood vessels and causing injury of the smaller blood vessels, and pulmonary renal syndrome will happen as a sequela. Here is the diagram that is summarizing the pathogenesis of ANCA-associated vasculitis. We have an antigen that will be recognized by neutrophils, and neutrophils will express these enzymatic antigens, proteinase 3 and myeloperoxidase over the cell's walls, and B cells will stimulate the antibodies and neutrophils will be bursting, and the complement system will be accumulating more of the neutrophils, and the inflammatory process will be persistent and continuous. Among patients with pulmonary renal syndrome due to Guttwasser syndrome, we have an antibodies called anti-GBM, which attack a specific type for collagen present in the alveolar wall and the glomeruli. As a result of this antigen-antibody immune complex, pulmonary renal syndrome will occur in terms of alveolar hemorrhage and glomerulonephritis. In patients with systemic lupus erythematosus, we have nuclear antigens will be presented by antigen-presenting cells, and these antigen-presenting cells will present these nuclear antigens toward the adaptive immune system in terms of T cells and B cells, and B cells will form antibodies, and this antigen-antibody reaction will circulate in the blood, and releasing cytokines will cause these devastating complications. Here is in this figure, we have a summary about the pathogenesis of SLE in terms of specific antigens in genetic susceptible individuals will cause stimulation of the immune system, and the antigens with antibody complex will cause these severe manifestations in terms of pulmonary renal syndrome and other features. What about the clinical features of pulmonary renal syndrome? We have the constitutional symptoms in terms of fever, fatigue, myalgia, arthralgia. Respiratory symptoms are important, like shortness of breath, cough, with or without hemoptysis. We should remember that about 1/3 of the patients with pulmonary renal syndrome may not have hemoptysis, but they will have severe shortness of breath, and cough. So, hemoptysis might be present or not present among patients with pulmonary renal syndrome. Lower limbs edema and dark colored urine could be a presentation among patients with pulmonary renal syndrome. The patients having these clinical features are usually coming with acute and rapid deterioration in their respiratory function in terms of hypoxemia, diffuse lung infiltrate, and abnormal renal profile. And they will be admitted under ICU care primarily. Some important points to remember about pulmonary renal syndrome is that pulmonary renal syndrome is a life-threatening clinical syndrome associated with severe lung and kidney dysfunction associated with a higher risk of morbidity and mortality. The clinical features are non-specific, but the patient might present with constitutional symptoms and respiratory manifestations. Pulmonary renal syndrome occurs more frequently due to an underlying systemic immune-mediated disorders like ANCA-associated vasculitis, Goodbuster syndrome, and systemic lupus erythematosus. Thank you.
So thank you, Dr. Faisal, for this nice actually presentation about the pathophysiology for the pulmonary syndrome. So just to emphasize the take-home message, so as Dr. Faisal he mentioned, and for me as a pulmonologist and intensivist, so pulmonary syndrome, as I mentioned, they present with really non-specific presentation. The high degree of suspicion is very important. And the rapid diagnosis is important because the rapid management is important to save the patient a long journey of management and save him the deterioration. So that will actually take us to the next step and to our next expert, Prof. Mohammed Omair. But Prof. Mohammed Omair, he's professor of internal medicine and rheumatology in King Saud University and King Khalid University, King Khalid Hospital of the King Saud University and Medical City. He's actually the founder and he's the president of the Rheumatism and the Fibromyalgia Association in the Saudi Arabia. So he will actually talk to us about the management for the patients with the pulmonary syndrome, and we will actually mainly concentrate about the patients who present to the ICU. Thank you very much. So the floor is yours, Prof. Mohammed.
Can you play the recording? Yeah. I would like to thank my colleagues to invite me to talk about the management of pulmonary renal syndrome in the ICU, slaying the two-headed dragon. This is going to be my agenda. And first, I would like to tell you that dragons, especially two-headed dragons, have been in the ancient mythology of different empires and cultures, including the ancient Greek, the Babylonian, Iranian, Slavic, and even the Latino Inca empires. Now, general concepts about pulmonary renal syndrome. First, it requires urgent ICU admission, even if the patient presents in a clinically stable condition, especially patients who come with unilateral pulmonary infiltrate. As you know, pulmonary hemorrhage or diffuse alveolar hemorrhage can start unilaterally and then diffuse to the remaining of the lung. It is associated with high mortality, even at the best centers. So basically, the initial reports of pulmonary renal syndrome survival was about 50%, It could be the first presentation of the autoimmune disease, so you don't have to have a background autoimmune disease to diagnose it. And of course, patients can tolerate it. The general concept of management, you have to start pulse or high-dose steroids as soon as possible. And whenever there is a high suspicion of anti-glomerular basement membrane, you have to start total plasma exchange before the return of the investigation. Of course, we have to treat the underlying cause, and it's usually an infectious trigger, either bacterial or viral. And in some diseases, the timing of introducing drugs such as cyclophosphamide or rituximab could be in the ICU, usually after ruling out or controlling any ongoing infection. So the classical steps would be to do bronchial alveolar lavage, to send it for stain and culture, and then patient is already on antibiotics for 48 or 72 hours. Cultures are negative. Then the ICU with the primary team would decide to add cyclophosphamide or rituximab in the management. And of course, this medical emergency requires the efforts of all services that are engaged, including rheumatology, pulmonary, hematology, and nephrology. Let's start with good posture syndrome or anti-glomerular basement membrane, which actually was the original disease that pulmonary renal syndrome was described in the early 70s. So basically, it's a type 2 hypersensitivity reaction. So these are circulating antibodies that are targeting antigens into the tissue of the glomeruli and the lungs, namely collagen. And in this disease, total plasma exchange is the most that makes sense in the management of these diseases, unlike lupus and ANCA-associated vasculitis, where it is mainly of type 3 hypersensitivity reaction. Anti-GBM can present as isolated rapidly progressive glomerulonephritis. Usually, these patients have 50 to 100% crescent formation in the renal biopsy. And it is the only disease that require monitoring of autoantibodies. So basically, you need to do the anti-GBM antibodies and do the plasma exchange till either the autoantibodies disappear from the system or the patient completes 14 days on plasma exchange. There is some interaction between anti-GBM and ANCA. So 30% of the anti-GBM patients can have a positive ANCA, while 15% of the ANCA-associated vasculitis patients can have a positive anti-GBM antibody, which might affect the disease phenotype in the presentation, but these are epidemiological data rather than clinical implication. And the KDOQI guideline, which are driven by the Nephrology Society, published in 2021, the most recent guideline in glomerular disease, which they focus on both acute and chronic diseases, including RPGN. And you could see here in the algorithm that you have to start plasma exchange even if the patient did not have yet the antibody back, once you have a high suspicion of anti-GBM, and then adding cyclophosphamide or rituximab could be the next step once the patient is stable and there are no ongoing active infection. Pulmonary renal syndrome has been heavily described in lupus during training programs, but in the literature, this does not translate very poorly, very well. So it is poorly described in the literature, and a recent systematic review published in 2023 have shown that only 19 studies have discussed pulmonary renal or lung kidney syndrome in patients with lupus, and basically the management is very similar to anti-GBM with high-dose steroids, total plasma exchange, adding cyclophosphamide and rituximab as a second line. But what is different that in lupus pulmonary syndrome, the required number of plasmapheresis sessions is 3 to 5 maximum, and then you re-evaluate the need of further sessions. In catastrophic antiphospholipid syndrome, I will just discuss quickly about the new antiphospholipid syndrome criteria, which present as an additional value for our ICU colleagues. So basically, if you remember the hypothesis behind antiphospholipid syndrome, where you have circulating antiphospholipid antibodies directed at, against endothelial lining of blood vessels, both arteries and veins, with a second hit, which is usually triggered by an infection, which lead to complement activation and the coagulation cascade, leading to diffuse thrombosis in the arteries, veins, or even in the placenta, and the development of the syndrome. Now, the catastrophic APS criteria usually require to be definitive 4 elements, which include involvement of 3 or more organs within 1 week or less, with at least 1 organ has histopathological confirmation of arterial occlusion, and of course the autoantibodies that have been tested positive 12 weeks apart. So some of these patients, their initial presentation is CAPS, so you cannot have the element number 4 unless they survive for the next 12 weeks, and some of these patients, they actually die. And this is why they develop the probable CAPS, where you have one of the elements is missing, and you can then initiate the management. The original Sapporo APS revised criteria, or the initial were in the early 2000, then they had a revised version in 2006, which required 1 clinical criteria, which is vascular thrombosis either in an artery or a vein, or a pregnancy morbidity, including intrauterine growth retardation, preeclampsia, recurrent abortion, or intrauterine fetal death, plus 1 laboratory criteria, which include the anticardiolipin or beta-2 glycoprotein antibodies, or the lupus anticoagulant, which is a functional test to evaluate for an autoimmune phenomenon. Now, the American College of Rheumatology and the European League Against Rheumatism developed new criteria where they included, instead of number of criteria, scoring and weight for each of these criteria. And you could see here venous thromboembolism, when there is a high risk factor, it gains 1 number, while if there is no high risk factors, it goes to 3. You could see non-vascular and non-pregnancy criteria, like cardiac vegetations, 2 and 4 points. You could see lipido reticularis. You could see the weight of the different obstetric manifestations, and the titer of the autoantibodies is again has different weights. So a single positive lupus anticoagulant is 1 point, but a persistent is 5 points, while a high positive IgG, anticardiolipin, and beta-2 glycoprotein will provide 7 points. And basically, you have to have 3 clinical points, and you have to have 3 laboratory points to diagnose antiphospholipid syndrome. And this will lead to a higher sensitivity and the diagnosis of antiphospholipid. And this will again lead to a quicker diagnosis of patients with catastrophic APS once you have the multi-organ involvement. This is the CAPS registry. It includes more than 1,000 patients now with 60% of these patients having primary antiphospholipid and about 30 having secondary to lupus or associated with lupus. And you could see here the different manifestations of the caps on the kidney and the lungs. So you could see acute renal failure, proteinuria, arterial hypertension or malignant arterial hypertension, hematuria, and in the lung you could see ARDS, pulmonary embolism, alveolar hemorrhage, and pulmonary edema. And the management of catastrophic APS include the first line, which is pulse steroids, full dose heparin, either intravenous or subcutaneous, and of course, treating the underlying cause. If a patient has a lupus associated CAPS with thrombo-microangiopathic hemolysis, you would recommend to add plasma exchange, while in primary CAPS with severe immune thrombocytopenia, IVIG would be a better option, but you can always combine IV immunoglobulins and total plasma exchange in severe cases. Then once infection is ruled out, you can either add cyclophosphamide or rituximab with possible antiplatelet. And there is, of course, the role of adding eculizumab when it is affordable to treat patients with CAPS, mainly with lupus association. The next question is about total plasma exchange in ANCA-associated vasculitis. So basically, it started in 2007 with a trial called the MEPEX trial, which showed in patients with rapidly progressive renal failure and a creatinine of 500 or patient being on dialysis, adding total plasma exchange to the treatment of patients with ANCA-associated vasculitis in addition to steroids and oral cyclophosphamide, improved the 3 months renal recovery by 49% compared to the steroid-only group, which is 69%. Then this was followed by a systematic review, which favored the use of total plasma exchange or PLEX in RPGN, regardless of the underlying cause. So the rate of end-stage kidney disease at 6 months has been better in patients who used total plasma exchange. I would just like to draw your attention that most of the clinical trials in this systematic review were performed before the year 2000, so most of them are very old and are pushing the line toward the PLEX. But yet there is some signal, but when you look at mortality, we don't see any added benefit of adding total plasma exchange in patients with RPGN. Then came the PEXIVAS study, which is the largest randomized clinical trial on patients with ANCA-associated vasculitis, published in New England Journal of Medicine. It took them 10 years to recruit and finish the study, so it started in 2010 and was completed in 2020, where they evaluated one of the outcomes is the adding plasma exchange to the standard of care. And you can see from the Kaplan-Meier curve, there is no added value of adding plasma exchange to the management of patients with acute presentation of ANCA-associated vasculitis, neither in death, end-stage kidney disease, remission, or rate of infection. But remember, if in this clinical trial, patients who had diffuse alveolar hemorrhage were underrepresented. So the point of total plasma exchange addition was mainly on renal outcomes rather than pulmonary outcomes. And this has led to putting plasma exchange as an option rather than a standard of care. If a patient has rapidly progressive disease, you can see the interrupted line in the RPGN, which consider plasma exchange as an add-on therapy to, in addition to corticosteroids or rituximab and cyclophosphamide. Then the same trial, the Pixivas, also answer another question. Should we give less steroids in these patients? You could see this protocol gives us an important lesson that whenever you have a patient in the ICU with an autoimmune disease, regardless of the weight, if the weight is 100 kilos or 110, you should not give exactly 1 milligram per kg. All protocols in rheumatology has given the maximum dose of corticosteroids of 1 milligram per kg to be 75 or less. So you should not move on to a higher number. And this will actually reduce steroid-related myopathy, electrolyte imbalance, and of course the cumulative dose that we deal with as rheumatologists later on when these patients are in maintenance. And in the protocol, they divided the patients into a standard dose, so a tapering of 10 milligram per kg over 1 to 2 weeks. And they reduced dose where in the second week, they dropped the dose of steroids by 50%. And you could see again, there is no difference in the outcome of death or end-stage kidney disease with the reduced or standard dose, but also patients who receive the reduced dose of glucocorticoids had about 40% less risk of infection at 1 year. And there is a new drug called avacopan, which is a C5a receptor antagonist, which blocks the priming of neutrophils that are essential in the pathogenesis of ANCA-associated vasculitis, and after the apoptosis of these neutrophils, this will lead to development of the ANCA antibodies, which will later on increase the activation of neutrophils. So the avacopan has been shown to reduce activation neutrophils and breaking the vicious cycle. And a very famous trial called the Advocate study actually replaced corticosteroids. So these patients received avacopan instead of corticosteroids. And we could see that avacopan was superior in reducing the rate of relapse in these patients. Now, it has been added now as an alternative to corticosteroids. The only problem with avacopan that is very expensive. And I believe that it might be an excellent choice to add it over glucocorticoids if it is affordable or available in your healthcare system or hospital. Other causes of pulmonary renal syndrome include cocaine, cryoglobulinemia, and the management of cryoglobulinemia is very similar to what we have discussed with corticosteroids, and total plasma exchange is a very important player in the management of cryoglobulinemia because you remove the cryoglobulins from the blood and reduce the inflammation. IgA nephropathy has been a very famous disease causing hematuria and renal impairment, but in very rare cases, less than 5%, it can be associated with a milder form of diffuse alveolar hemorrhage. And also systemic sclerosis has been described by itself to cause a pulmonary renal syndrome, but whenever you see systemic sclerosis having diffuse alveolar hemorrhage, you have to consider a systemic sclerosis overlapping with lupus. And this is a beautiful summary from a review article published about 3 years ago, showing how to manage patients with pulmonary syndrome based on their underlying disease. So you could see induction with the glucocorticoids is a standard of care, and then considering plasma exchange in patients with ANCA-associated vasculitis, while in anti-GBM it is a standard of care. In the APS, you have to give anticoagulation in addition to what has been described. And in lupus, again, considering PLEX is one of the options, but it is not required in all patients. And the final point is that managing these patients require multidisciplinary care. So Patients with pulmonary renal syndrome might have other organ involvement, including acute coronary syndrome with an MI ongoing, which complicates the management of these patients, or a stroke, which again will complicate the use of anticoagulation if the patient has APS or catastrophic APS. We usually require our hematologist to help us mainly with the total plasma exchange and the management of the immune thrombocytopenia. And of course, the pulmonologist play a major role in the bronchoalveolar lavage and taking the samples, and the nephrologist arranges the hemodialysis in the ICU. So these patients are usually managed in coordination between the rheumatologist and intensivist till they come out of their critical period. So in conclusion, pulmonary syndrome requires swift action to reduce mortality and time of recovery. Anti-GBM requires rapid introduction of total plasma exchange once a suspicion is high. Pulmonary syndrome related to lupus is based on uncontrolled studies and has been not well described, and we don't have any strong evidence on plasma exchange. The new APS classification criteria include many previous non-vascular manifestations that will facilitate the early diagnosis of APS and CAPS as a complication and justify early treatment initiation. The role of total plasma exchange in the acute management of ANCA-associated vasculitis has transformed from a standard of care to an optional management. Newer steroid regimens provide a lower risk of infection and smaller long-term cumulative dose. And finally, the optimal management is provided through a multidisciplinary team using the best evidence-based treatment in these patients. Thank you.
All right. Thank you very much, Prof. Omair, for this nice presentation about the management of the different actually disease entities about the pulmonary renal syndrome. Appreciate it so much. So, looking at the Q&A box, so we have it's rich actually. So I can conclude actually we have actually three types of questions or three types of comments. Comments related to the volume, which actually I noticed that. So I will forward the comments to the technical support. So I think we have an issue with the volume because actually the volume was actually low for both presentations. So they can keep that in their mind for the future webinars. We have maybe an issue with the volume. The other comments related to our fellowships and certificates, so that will be actually these comments will be forwarded to our administrative support for our organization. So they will take care, I believe, Prof. Amr, they will take care regarding these comments related to the certificate and the fellowship. Now let's talk about our topic. So we have a couple of comments related to the pathophysiology and the diagnosis. So let me ask Dr. Faisal now regarding the me and Dr. Heba, we can actually give our comment in that regard. So do we need actually, can bronchoscopy diagnose or biopsy from the lung the vasculitis, or do we need kidney biopsy? So do you want Dr. Faisal to comment about that question?
Yes, Prof. Fadi. Yeah, thank you very much. So I would like to say that the biopsy from the lung is not that much specific. Sometimes it might miss the necrotizing granuloma, but the kidneys is showing us that more features about ANCA-associated vasculitis. So we are going to avoid lung biopsy to go more toward kidney biopsy. For the diffuse alveolar hemorrhage, I mean, if the patient has hemoptysis, a drop in the hemoglobin, with the features is more going with pulmonary renal syndrome, that's straightforward. But sometimes we have the patient like straightforward to the ICU, doesn't have hemoptysis, but is requiring mechanical ventilation with high setting. So this is like we need a bronchoscopy more just to exclude infection like PCB, other infection, before as we are going to give the patient strong immunosuppression, steroid balls, cyclophosphamide, or rituximab. So this is my opinion.
Yeah, I believe that I agree with you. Most of the time, the lung biopsy will be challenging. Those patients are on high oxygen requirement, and to do lung biopsy will most likely will be complicated with pneumothorax. And if they are not intubated, they will end up to be intubated, and if they're intubated, it will be challenging. The best that you can get from them is lavage, and that will help with the diagnosis. And the kidney biopsy will be easier. So I believe the kidney biopsy is the easiest for diagnosis. Another question is actually talking about the COVID. So here, can we consider COVID as one of the pulmonary renal syndrome? So I'm not sure the COVID. COVID. They presented with renal actually. Yeah, sure, for sure. Especially the first wave of the COVID, they presented with renal involvement in addition to the pulmonary. But I'm not sure for you as a rheumatologist if you can comment about that, regarding the pathophysiology of COVID. You and Dr. Omair, or Prof. Omair, if you want to comment about that.
Prof. Mohammed, do you like to add a comment before Dr. تفضل.
No, please go on, go on. I will, if you want, I can complete.
Yes, so regarding the COVID-19 induced pulmonary renal syndrome, so we are seeing like frequently more cases nowadays about COVID-19 infection-induced ANCA or the COVID vaccine-induced ANCA vasculitis. So it might present. So we have many cases, although it's not the common, but we are starting to see in them. Like we have patients received the COVID vaccine, and after that, by 3 months, started to have respiratory symptoms, cough and shortness of breath. Then the CT showed like lung nodules, but after that, by 6 months, started to have alveolar hemorrhage. So it seems that the vector inside the vaccine is its immunogenicity is very strong and introducing an antibodies from the B cells, and one of them is ANCA. So this is like one of the possibility. In addition to that, that the COVID-19 viral particles, they are circulating in the blood with a highly virulence, and is causing like more endothelial injury. And these endothelial cells, the debris from the endothelial damage, will circulate in the blood and causing like an antigen. So triggering neutrophils, triggering antibodies, and after that, the ANCA will happen. Yes, so COVID-19 infection or vaccine, might be a trigger for ANCA-associated vasculitis. And even in the literature, we have some cases about SLE-like manifestations in COVID-19 infection. So after the infection, the patient started to have RBGN, and it's been shown that the patient have viral particles in the electron microscope. So again, COVID-19, yes, is one of a great trigger for pulmonary renal syndromes diseases. تفضل Prof.
And you manage them the same way that we manage the classical lupus or ANCA vasculitis, whatever.
Yes, because actually they are coming like later on, like 6 months, 3 months, but the presentation started. The chronic presentation is started after the vaccine or after the infection. It was like an indolent course with a cough and shortness of breath. So it is recovered, like the fever recovered, the fatigue recovered, myalgia recovered, but these respiratory symptoms still remaining. So I will manage them like the patient who have a genuine ANCA-associated vasculitis or genuine SLE, because now the trigger causing the activation and then disappeared. So we have to treat them, I think, in the similar way as genuine diseases.
Fine. Another point, which actually is a very common scenario, I believe me, Prof. Amr and Dr. Heba, or Prof. Heba, we see it, is that very common that those patients, they present with suspicion of infection, or they might have an infection. One of the very challenging cases that we had in the ICU recently, there is a lady that she had actually staph aureus bacteremia, in addition to very catastrophic and very stubborn, I would say, lupus and antiphospholipid syndrome. So in that cases, when you have suspicion or you have well-proven infection in addition to the whatever lupus or ANCA vasculitis, so how would you manage those patients with the immune suppression that they need and antibiotic? So would you manage them in the same degree of the immune suppression, or would you give them tailored immune suppression in those patients when they have infection established or suspected?
Yes, if the patient is already diagnosed as ANCA-associated vasculitis or this pulmonary hemorrhage, okay, I confirm that this is a case of pulmonary hemorrhage by bronchoscopy and sequential. I did a bronchoscopy and I find falling hematocrit. I found hemosiderin-laden macrophages, and it is established case of, for example, alveolar hemorrhage. Plus, as you have said, it's established case of fulminant infection. So I think in these cases, as recommended by the American College of Rheumatology, the intravenous immunoglobulins here play an important role in the management of these cases. I think aggressive immunosuppressant will be held apart, and I will start with intravenous immunoglobulins together with steroids if there is a case of fulminant severe infection.
I'm not sure, Prof. Omair, you spoke about the management. So would you hold on the immune suppression if you have established infection?
Yeah, so I agree with my colleague is that corticosteroid is the main line of treatment, and it has the quickest onset of action. And basically, drugs like rituximab and cyclophosphamide have a very long half-life and impact on either the bone marrow in the case of cyclophosphamide or the CD20 positive B cells, which will cause significant depletion. So basically, you start with IV corticosteroids and plasma exchange if indicated based on the underlying disease. Intravenous immunoglobulins, as discussed by Prof. Heba, is an excellent and safe option to buy us some time, but you don't have to have a full treatment of the infection. So, for example, if you have a patient who has a pneumonia that triggered the pulmonary renal syndrome or the diffuse alveolar hemorrhage, once the patient is on adequate antibiotics, you have done the first culture, which was positive, then the second culture became negative, then you have to discuss along the intensivist, the rheumatologist, and include the infectious disease specialist to give us the green light then to move on to more aggressive therapy. So basically, it is very important to evaluate the patient on a daily basis and then dynamically change the management in a multidisciplinary approach. So I can assure you that every patient has somehow a different course than the other. And remember, the immune system, when it is sick, it cannot combat infection. So treating the autoimmune disease actually help the patient to fight the infection. So when we give steroids, we're actually empowering the patient to treat,
Fight the infection.
improve on the infection.
I see. There is a question, actually two questions here. One of them is that, do we give both rituximab and cyclophosphamide together?
Okay, so there is a trial called the REV trial. This was published in 2010. And the REV trial was the game changer for ANCA-associated vasculitis, where rituximab have been shown to be non-inferior to cyclophosphamide in the REV trial. Now, the REV trial had a mixed population of patients who were cyclophosphamide naive and in patients who were cyclophosphamide resistant or relapsers after cyclophosphamide. And they found that patients who already had cyclophosphamide in the past had a better response to rituximab. Then some fewer trials have shown that combining cyclophosphamide and rituximab is safe and effective in treating. But usually we as rheumatologists we go with one which is now the current standard of care is rituximab in patients who are refractory to many agents who combining rituximab cyclophosphamide is an approved practice.
And do we recommend to monitor rituximab during the management with like IgG or CD19 count?
So just as a background, when you deplete CD20 cells, the usual time of repopulation is 4 to 6 months based on the patient. And the practice in the oncology subspecialty and even neuro subspecialty is monitoring the repopulation of B cells after rituximab. But in the two approved indications, rheumatoid arthritis and ANCA-associated vasculitis, there is no evidence to recommend routine assessment of CD19 repopulation or CD20 repopulation.
So you don't need to monitor with immunoglobulins or CD19.
No. And this is mainly an issue of long-term management. And I don't want to take a lot of your time, but basically one trial have evaluated rituximab as needed in patients who actually had a relapse or repopulation or routine 6 months rituximab treatment, and they found that rituximab every 6 months was associated with a less risk of relapse. Maybe Dr. Faisal, if you want to add any additional points on that.
As Prof. Mohammed said, regarding the rituximab, it will be given like every 6 months, better than we are measuring the level, because actually the disease will be active. And we know that some patients, they have active disease even when the CD19 or CD20 being subsided, especially in the beginning of the disease. So as Prof. Mohammed said, there is a big trial, it's called Medicine 2. They discuss like what the Prof. Mohammed said about the tailored versus based on the CD19 repopulation or just regular dosing of rituximab, and they found that the regular dosing of rituximab is really effective in reducing the relapse. Although they are like more frequent, they give them more frequent, like 5 times, and that the tailored one is 3 times, but is more effective in reducing the relapse. So again, especially in the beginning of the disease, we need to continue the treatment because ANCA will carry a risk of relapse during this period. Yeah.
For how long do you continue the rituximab?
So this is actually a very difficult question that the literature will not be able to answer. So basically, the American-based trials have been very aggressive in reducing or stopping corticosteroids in their protocols. And this actually shows you the rate of relapse, because induction of ANCA-associated vasculitis is actually a very successful point because most of patients, they respond to induction. The main problem is the relapsing remitting course that will lead to damage and requirement of more immunosuppressive therapies. But the current practice now is at least 24 months or 2 years.
Rituximab, not steroids.
Rituximab. Yes. I'm just coming to rituximab. So steroids, you have to stop it within 6 months to a year if patient is able. Now, European uncontrolled registries have actually recommended that continuing steroids for long period of time, exceeding even more than 2 years, is associated with less relapse. But rituximab, the current now guideline is to give at least 2 years. And you can always give rituximab.
At least 2 years. So
yes. But you can always taper the rituximab. You can always taper the rituximab. So a patient can start on 1 gram every 6 months as maintenance. And then if he's stable, you can go to 500 milligram every 6 months, especially elderly people or patients who are at high risk of infection.
So I'm not sure, Dr. Amr, do we have time for more questions?
Yeah, maybe a couple minutes.
So maybe just a couple of quick questions, and the answer will be fast, Dr. Prof. Heba. So there are a couple of questions about the indications to admit to the ICU for the hepatorenal syndrome, and regarding the management of the ventilator and the dialysis management for those patients. So if you want to comment about the indications to admit to the ICU and how to ventilate those patients and how to dialyze them. Any
Please
special
mute yourself, Dr.
consideration?
Heba.
And you are muted, Dr. Heba, you are muted.
So regarding the pulmonary renal syndrome, if the patient has refractory hypoxemia, the patient has deterioration in his oxygen requirements, increasing oxygen requirements, deterioration regarding his kidney functions. The patient, of course, should be monitored in the ICU. Regarding mechanical ventilation, first of all, we give supportive treatment, oxygen therapy, and we start on escalating the oxygen therapy according to the patient's requirement. Renal replacement therapy is usually, we try to postpone it as much as we can. We start as soon as possible with plasma exchange and immunosuppressive treatments and high-dose corticosteroids in order to save the kidney. However, if the patient is not responding to any of these measures and the kidney is still deteriorating, we start to consult nephrologists and start the renal replacement therapy. But usually the patient that you need renal replacement therapy are of poor prognosis and poor outcome. So long the patient is correctly diagnosed and start the proper treatment in the proper time, the patient, in my experience, even if the patient needed mechanical ventilation, will be rapidly weaned off. So the problem is to when to start treatment. Usually these patients, first of all, we do the collagen profile, we do the laboratory test, the ANCA and the anti-GBM, but usually the labs doesn't reveal these results in a quickly manner. Usually, like we have 3 to 4, maybe up to 5 days in order to get these results available. So actually what we do, we usually start a plasma exchange together with cyclophosphamide versus rituximab and high dose.
Just the question was, do you have any special, let's say, threshold for admitting them to the ICU, or you have the usual criteria for other patients?
Usually criteria for any patient with respiratory failure, the patient presenting with
and regarding ventilating them, so when you ventilate them the usual ventilating parameters for the patients with ARDS, or you have special also management strategy? I think maybe we have an issue with the net with Prof. Heba. So anyways, I think maybe we lost the internet connection with her. For me as an intensivist, so as Prof. Heba, she mentioned that I will have the same criteria for admitting them to the ICU for those patients. For sure, when I discharge them from the ICU, I will have some reluctance, and I have a high threshold to discharge them from the ICU because they are heavily immune suppressed. So I will have a strict criteria when I discharge them from the ICU before I discharge them. Now, regarding the ventilation and the dialysis, so I manage them as usual patients. When they are in ARDS, the same ARDS strategy, and the dialysis same strategy. Maybe just final comment from Prof. Omair about the plasmapheresis. So can you give us just the quick conclusion about when do we use plasmapheresis and how many sessions for pulmonary renal syndromes?
May I comment on just the criteria
sure.
for admission, just in a few minutes? We usually have this kind of let's call it long discussions with our colleagues in the ICU on the criteria. Once we as rheumatologists, once a patient with an underlying rheumatic disease or high suspicion of rheumatic disease is diagnosed with pulmonary renal syndrome, it is better that this patient need to go into a critical care area, ICU, high dependence unit, because these patients cannot stay on the floor because they can deteriorate very quickly within hours. You could see a patient who started to have symptoms about a week ago and deteriorated over a week, and you could see a patient who deteriorated over 24 hours. So whenever we have a patient, for example, with lupus, who started to have fever, hemoptysis, and her creatinine increase or develop segments, we consult our colleagues in ICU, and they usually take them as soon as possible, even if they are not in a full respiratory distress or. And this is actually some a debate with some intensivists who do not agree to take them when they are stable. So I'm just telling everyone that this is an area of debate, and usually for us as rheumatologists, we prefer that these patients, they need to go into a critical care area with good monitoring instead of staying in the floor. In view of the plasma exchange,
just to complete your comment, because actually from what I have seen, I'm sure Prof. Omair you have seen, because some patients they crash very quickly for such patient for these patients. So that's why we want to catch them before they crash.
exactly. You know, we have some debates with pulmonologists when a patient comes with a unilateral infiltrate, and you tell them this is pulmonary hemorrhage, and they agree, they disagree. They said it's most likely a bacterial pneumonia, and then the patient has a 3-gram drop of hemoglobin. And these are very young people who are very responsive to treatment, so you can save their lives and put them back into the floor, into their regular lives. It's not like someone who's having organ failure and elderly. Most of patients with pulmonary syndrome are young people with an excellent outcome if we treat them aggressively and admit them early. I don't want to take a lot of your time, so I'm just going to go quickly on the plasma exchange. So basically, the plasma exchange in anti-glomerulus basement membrane, based on the Kiduku guideline, which is the most important or one of the most important renal societies, they recommend to do total plasma exchange for either a total of 14 days or till the anti-GBM antibodies disappear. In view of lupus, the uncontrolled studies recommend 3 to 5, but again, this is debatable because these are all uncontrolled data. And similarly, in patients with uncapsular vasculitis, when we decide to give total plasma exchange, we give 3 to 5 days and then we re-evaluate. So the decision to continue plasma exchange or hold plasma exchange can be re-challenged after finishing the sessions and the condition of the patient.
And what about the antiphospholipid syndrome?
For the antiphospholipid syndrome, again, you can give about 3 to 5 sessions and then re-evaluate. But as I have mentioned, in the catastrophic antiphospholipid syndrome, total plasma exchange might be of value if patient has an underlying lupus. In primary catastrophic antiphospholipid syndrome, IVIG might play a better role. And sometimes you can actually combine both. So you give the IVIG after the total plasma exchange in patients who are deteriorating or worsening. Catastrophic APS. Yes.
Let's say that you gave the steroids and you gave the rituximab, and still the platelets count is not going up, and the patient actually is still in the catastrophic syndrome. So do you still like bridge him with the plasma exchange?
Yes, so you could try, but now there are some other options like eculizumab, which is again an extremely expensive medication that might not be available in most healthcare systems or hospitals, can be an option in these patients. But the main problem with thrombocytopenia related to APS is not the consumption, rather than the antiphospholipid antibodies attached to the platelets, which will lead to their destruction in the spleen and the intravascular destruction. So a lot of it is treating like an immune thrombocytopenic purpura with IV corticosteroids and IVIG. But once the patient is really worsening, is having a bleed, you can attempt to give anything. Because, you know, in catastrophic APS, there is no controlled studies that will tell you this is better, this option or management is better than that other. And in a life-threatening condition like this, at the end, it's a shared decision between different colleagues and the patient or his family.
Exactly. I think that's a very golden sentence which you mentioned, that many of these cases, especially that when they get you are dealing with very severe and stubborn disease, that you cannot go with guidelines. So you have to deal with different multiple parameters, shared decision, as you said, and you have to deal with the case in front of you and reach a conclusion with your colleagues. So you cannot really rely on a guideline.
Continuous discussion, meetings, presenting the case, and sometimes hearing different opinions. So getting more than one rheumatologist, getting more than one nephrologist or pulmonologist to discuss the case. I really believe that multidisciplinary approach help to get the patient into his best chance of survival and reduce organ damage and mortality.
So I think I will conclude our webinar, which is a very actually nice webinar. It's a sad actually disease, or actually those patients, they are miserable patients, the pulmonary syndrome. Luckily that it's not really common, but when they present, they need, we can conclude that actually they need high alert or high degree of suspicion to diagnose them. One of actually of the Q&A that do we need to have established diagnosis, start treatment? No. High degree of suspicion, collecting all the information and what you have, and you can start treatment until you reach the final diagnosis while you are actually managing them. So it's really a very valuable and rich discussion. I appreciate the input from Dr. Heba with her case presentation, the valuable input from Dr. Faisal, Prof. Omair. They guided us through how to approach this syndrome, how to manage this syndrome. We went through the different management strategies. I really thank you very much. I have no more words actually to appreciate your efforts and what you contributed to us. Thank you very much. So it's yours, Prof. Amr.
Thank you so much, Dr. Fadi, for the great moderation, Dr. Faisal and Dr. Mohammed, Omair for the great presentation, and Professor Heba also for the great case-based discussion. I think the key here is the multidisciplinary team approach, because this is a life-threatening disease that cannot be treated by one physician. And this is the reason that we are here, you know, from nephrology perspective, from rheumatology, from pulmonology, and from intensive care background to discuss these challenging cases and to give our audience the up-to-date information. Just housekeeping stuff here. You should, all the attendees should receive their certificate of attendance in a couple of days. And by tomorrow, all of you should get the link to the YouTube recorded webinar. There is some unanswered question because we have many questions we cannot cover. Otherwise, we'll stay until tomorrow. So we are trying to answer this question privately, and we'll be in touch in the near future. Also, we have several questions regarding our Respiratory Critical Care Fellowship. We have your contact information, so we'll be in touch and we'll try to answer these questions either privately or through emails that we are going to send this week. With that, we will notify you with the next month Respiratory Critical Care Fellowship webinar. We'll let you know shortly about that. And I hope everybody have a great rest of his day or night or afternoon. Bye.